The biggest mistake I made as a younger doctor was telling my patients that memory loss was simply part of growing older. I repeated that line for years. I believed it. And now, looking back, I realize how many people I failed because of it. I am Dr. William Lee, and after more than 2 decades of practice, the case that changed my entire perspective did not involve a rare disease or an unusual patient. It involved a retired Tennessee farmer named Harold Jones, 78 years old, who came into my clinic with his daughter holding his arm because he could no longer recognize the road home to the farm where he had lived for 53 years. His family was preparing for the worst. His primary care physician had told them it was probably Alzheimer's. But when I reviewed Harold's medication list, I did not find a disease. I found 9 bottles, and 8 of those 9 bottles contained compounds with the documented ability to damage, impair, or chemically suppress the very brain chemistry required for memory to function. Within 6 months of working through that medication list carefully, Harold knew his daughter's name without hesitation. He knew the road home. He was not cured of aging, but he was no longer being chemically robbed of his mind without knowing it. That case made me angry. Not at Harold's doctors, who were doing what they were trained to do. I was angry at a system that never connected the dots, never added up the total burden on one human brain, and never once told Harold or his family what those pills were quietly doing inside his head every single night. That is why I am here today. Because if you are over 60, or if someone you love is over 60, and there is any memory loss, confusion, or brain fog happening in that household, you need to know what is on this list. The medications I am going to walk you through are not obscure. They are not rare. Several of them are sold without a prescription. Some of them are prescribed by well-meaning physicians who simply do not realize what long-term use does to an aging brain. I am not here to tell you to stop taking your medications. That decision belongs to you and your doctor. I am here to make sure you walk into that conversation informed. Now, the reason I am sharing this is not to scare you, but to empower you. Because once you understand this, you can do something about it. There is something genuinely hopeful waiting at the end of this conversation, and I will get to it. But first, let us start with number 9. And do not let the low ranking fool you, because this one is sitting inside the purse or medicine cabinet of millions of Americans right now. Number 9 is diphenhydramine. Most of you know it as Benadryl, the little pink tablet that people reach for when they cannot sleep, when allergies flare up, or when they need something inexpensive and easy. No prescription required, sold openly. And for decades, it has been treated like the safest thing in the world, precisely because it sits on a shelf next to vitamins and cough drops. But here is what happens inside your brain when you take it. Diphenhydramine belongs to a class of drugs called anticholinergics. What that means in plain language is that it blocks acetylcholine, the chemical messenger your brain uses to form new memories, to sustain attention, and to stay mentally alert. When you are 20 years old and your brain is producing acetylcholine in abundance, blocking a little of it is barely noticeable, but the aging brain produces less of it naturally with every decade. By the time you are 65, your brain is already running closer to its limits. Then you take something every night that further depletes that messenger, and you are essentially unplugging a wire that was already fraying. A 2023 study published in the Journal of Geriatric Cognitive Health followed older adults who used anticholinergic medications regularly. They found a 54% higher risk of dementia compared with people who avoided them, more than half again the normal risk, from something available in every grocery store checkout aisle. If you use diphenhydramine for sleep or allergies, speak with your doctor about alternatives. Loratadine, sold as Claritin, works on allergies without crossing into the brain the way diphenhydramine does. It is safer for the long term. Number 8 is the Proton Pump Inhibitors, omeprazole, pantoprazole, esomeprazole, the purple pill. These medications shut down acid production in the stomach, and they are prescribed by the millions for heartburn, reflux, and the burning discomfort after meals. People stay on them for years because stopping them causes the symptoms to roar back, and so it feels like the drug is the only thing keeping things under control. What the pharmacist rarely mentions is the reason that happens. Think of your stomach acid the way you would think of a river running through a mine. The acid dissolves certain minerals out of your food and carries them into your bloodstream. When you reduce that acid enough and long enough, the minerals do not get extracted. Chief among them is vitamin B12, which is the nutrient your nervous system uses to insulate its own wiring. Without adequate B12, that insulation deteriorates, signals misfire, the brain slows, thoughts get foggy, and most people attribute it to age. A large-scale study published in JAMA Neurology examined more than 73,000 people aged 75 and older. Regular users of proton pump inhibitors had a 44% higher risk of dementia than non-users. 44%. And there is a second mechanism on top of the nutrient depletion. These medications have also been shown in laboratory studies to increase levels of amyloid beta in the brain, which is the sticky protein that accumulates in Alzheimer's disease. If you take one of these pills every single day, that is the conversation to have with your doctor this week. Many people can taper onto a gentler class called H2 blockers, like famotidine, sold as Pepcid, which does not carry the same cognitive burden. Number 7 is the bladder medications. And specifically, I want to talk about Oxybutynin, sold as Ditropon. This drug is given to older adults who experience urgency incontinence, the sudden desperate need to reach a bathroom. The relief it provides is real. The embarrassment it spares people is real. But Oxybutynin is another aggressive anticholinergic, and this one crosses into the brain with remarkable ease. It parks itself in exactly the regions where memories are consolidated. In 2019, the British Medical Journal published a study of adults over 65 who took strong anticholinergic medications like Oxybutynin for more than a year. Their risk of dementia was 49% higher, nearly 1 in 2. And the crushing part of that statistic is that almost none of those patients had been warned. They were told this medication would calm the bladder. Nobody mentioned it might simultaneously be dimming the mind. The memory loss gets blamed on age. The medication gets refilled. And the cycle continues until someone like me sits down and actually counts the bottles. If you take Oxybutynin, ask your doctor about mirabegron, sold as Myrbetriq. It works through a completely different biological pathway and does not block acetylcholine at all. Most older adults get the same bladder control with dramatically less risk to their thinking. Number 6 is one that is going to surprise many of you because it is among the most prescribed medications on the planet, and it is prescribed with genuinely good intentions. Number 6 is statins, simvastatin, atorvastatin, sold as Zocor and Lipitor. These medications lower cholesterol and reduce the risk of heart attacks and strokes, and they belong in many people's lives. I want to be direct about that. This is not a case against statins, but it is the half of the story that almost never gets told at the pharmacy counter. Your brain is close to 60% fat by composition, and cholesterol is one of the primary building materials for the myelin sheath, the insulation that wraps around your nerve fibers the way rubber wraps around an electrical cord. Those sheaths allow signals to travel at speed and without leakage. They allow you to recall a word, recognize a face, remember an appointment. When you lower cholesterol aggressively enough with a fat-soluble statin, you can leave the brain short of a raw material it genuinely needs to maintain that insulation. The result looks identical to early cognitive decline. The breakthrough came when researchers realized that not all statins behave the same way. Fat-soluble statins like simvastatin and atorvastatin cross readily into brain tissue. Water-soluble options like pravastatin and rosuvastatin largely stay outside the brain. A 2023 paper in Frontiers in Aging Neuroscience found that adults over 70 who had been on fat-soluble statins for more than 3 years had a 26% higher rate of mild cognitive impairment. If you have been on a statin for years and you are noticing fog, that is a legitimate and important conversation to have with your prescribing physician about dose adjustment or a switch to a brain-safer option. Now, if you found those first 4 important, I want you to stay right here, because number 5 is the one that most often surprises people when they see it on this list. And what comes after it? Numbers 2 and 1. Those are the ones I consider genuinely urgent. Number 5 is Benzodiazepines. Lorazepam, sold as Ativan. Diazepam, sold as Valium. Alprazolam, sold as Xanax. These are among the most frequently prescribed medications in America for anxiety and sleep difficulties. They work by amplifying the brain's own calming signal, GABA. and the immediate effect can feel like genuine relief after months or years of racing thoughts and restless nights. The anxiety eases, sleep finally comes, and so the prescription gets refilled and refilled again, sometimes for years. Here is what is happening on the inside during those years. Benzodiazepines create a slow, progressive sedation of the whole brain, not just the anxiety system. The regions responsible for learning, for forming new connections between ideas, for retrieving a name or a date, those regions slow down proportionally. A 2022 study published in the British Medical Journal followed more than 8,000 seniors over 6 years. Those who used benzodiazepines for longer than 3 months had a 51% higher risk of developing Alzheimer's disease. The longer-acting medications like diazepam, which remain in the body longer and accumulate in fatty tissues, appeared to be even more problematic. Many patients I have spoken with describe a kind of emotional flatness that develops gradually. They notice they are not fully themselves. They feel muted, slower, and they have been told it is just age or stress or the natural course of things. It is none of those. It is a chemical pattern that is entirely identifiable once you know to look for it. Now, there is something critical I must say about this one. If you have been taking a benzodiazepine for more than a few weeks, do not stop abruptly. Abrupt withdrawal from these medications can be medically dangerous, including seizures. Work closely with your physician on a gradual taper over weeks or months. The path out exists, but it must be taken carefully, with supervision. Buspirone can help with anxiety without the cognitive cost. Certain forms of behavioral therapy designed specifically for insomnia and anxiety have shown strong results without touching brain chemistry at all. Number 4 is Amitriptyline, sold as Elavil. It is an older antidepressant that is still prescribed today for 3 different purposes: depression, chronic nerve pain, and sleep difficulties. That versatility is exactly why it became so widespread and why it is still in use decades after newer and safer options became available. But beneath its apparent usefulness, amitriptyline is one of the most potent anticholinergic compounds still in common use. It blocks acetylcholine so aggressively that with long-term use, memory problems stop being a side effect and begin to resemble an expected outcome. A landmark study published in JAMA Internal Medicine in 2015 followed more than 3,400 adults aged 65 and older over a 10-year period. Those with the highest cumulative exposure to anticholinergic medications, including amitriptyline, had a 54% greater risk of developing dementia. 54%. And the pattern that emerged from the data was particularly troubling. The damage was not limited to high doses. Even low nightly doses taken consistently for years produced measurable cognitive effects. If you take amitriptyline for nerve pain, duloxetine or gabapentin may offer similar relief without the same burden on your brain chemistry. For sleep, a very low dose of doxepin, which is considerably gentler on the anticholinergic pathway, may be a viable alternative. For mood concerns, newer antidepressants such as sertraline or escitalopram are generally considered far safer for long-term cognitive health. These are all conversations worth initiating with your doctor, not in a confrontational way, but as an informed patient who has done their homework. Number 3 on this list is paroxetine, sold as Paxil. And this one belongs in a category by itself, because most people who take it believe they are taking one of the safer options. Paroxetine belongs to the SSRI family, the same family as sertraline and escitalopram, which are genuinely considered safe for long-term use in older adults. But paroxetine is the single SSRI that carries strong anticholinergic activity. That one property sets it apart from its entire drug class. And yet, because it wears the SSRI label, it is frequently assumed by both patients and physicians to be equivalent in safety to its relatives. A large review published in Frontiers in Psychiatry in 2021 examined older adults taking different SSRIs and found that paroxetine users showed measurable declines in short-term memory, word recall, and sustained attention within the first 12 months of use. Seniors taking paroxetine were 30% more likely to show early signs of cognitive impairment than those on other antidepressants. The American Geriatric Society placed it on the Beers criteria, the the formal clinical catalog of medications considered potentially inappropriate for seniors precisely because of these concerns. The solution here is relatively straightforward. In most cases, paroxetine can be transitioned under medical guidance to sertraline or escitalopram, which provide equivalent mood support without the anticholinergic burden. If you take paroxetine and you have noticed changes in your thinking, that switch is worth asking about directly at your next appointment. Number 2 is antipsychotic medications. And this entry concerns me more than almost anything else on this list, because many of the older adults currently taking these drugs never knowingly agreed to take an antipsychotic. They were told they were receiving something for sleep, or for agitation, or for restlessness. The names you might recognize include quetiapine, sold as Seroquel, risperidone, sold as Risperdal, and olanzapine, sold as Zyprexa. These medications were originally developed and approved for serious psychiatric conditions, including schizophrenia and bipolar disorder. Today, they are routinely prescribed off-label to older adults in nursing facilities and private homes for behavioral symptoms that are difficult to manage: confusion, restlessness, resistance to care. What those families are rarely told is what the drug is actually doing to the brain in the process of quieting those symptoms. A 2022 study published in Lancet Healthy Longevity followed more than 25,000 older adults and found that those given antipsychotic medications for behavioral symptoms were 71% more likely to experience worsening cognitive decline within a single year, even among those who had no prior dementia diagnosis before treatment began. 71%. These medications suppress dopamine, a chemical involved not only in mood, but in focus, memory retrieval, and planning. Reduce dopamine enough, and the brain becomes slower, less responsive, less present. Families describe watching someone become dull, flat, almost absent, and they grieve a decline they believe is disease progression when the cause is sitting in a pill organizer on the nightstand. If you or someone you love is taking one of these medications for behavioral reasons, ask the prescribing physician directly. Why was this started? Is it truly necessary? And is there a plan to reduce or discontinue it? Many behavioral symptoms in older adults respond well to consistent daily routines, reduced environmental stimulation, treatment of hidden pain, and better sleep management. Medication should be the last resort, not the first answer. And now, we arrive at number 1. I told you at the beginning of this video that what I found in Harold Jones's medication cabinet was not a single drug. And that is exactly what number 1 is. Number 1 is not a medication. Number 1 is anticholinergic polypharmacy, the silent accumulation that nobody calculates, the total burden that no single doctor, no single pharmacist, no single prescription ever accounts for. Polypharmacy simply means taking many medications simultaneously. Anticholinergic burden is the combined effect of all those medications working on the same chemical system in the brain at the same time. And here is why this is the most dangerous item on this entire list. Every medication I described today, from the Benadryl to the Paxil to the antipsychotics, works in part by blocking or suppressing acetylcholine. Individually, some of them produce only modest effects. But when you stack them, the burden on that one chemical system does not add up. It multiplies. Let me tell you what I found in Harold's chart. He was taking Diphenhydramine every night for sleep. He was taking Oxybutynin daily for bladder urgency. He was taking Amitriptyline at a low dose for nerve pain in his hands, damage from decades of farm work. And he was taking quetiapine, which had been prescribed in a nursing consult 6 months earlier for nighttime agitation. 4 medications, each one prescribed for a legitimate reason. Each one reviewed individually and considered acceptable. Nobody had ever looked at all 4 together and calculated what they were doing collectively to his acetylcholine system, which was already naturally declining because Harold was 78 years old. That combination was not giving Harold Alzheimer's. It was chemically producing something that looked exactly like Alzheimer's in every observable way. Think of it like this. Imagine a water tower that supplies a neighborhood. It starts full, but you have a small leak in one pipe, another slow drain open on the east side, a third valve left partially open at the bottom. Any one of them alone is manageable. All 3 running simultaneously day after day, and the tower empties before anyone notices anything is wrong. A 2022 study published in Age and Aging tracked more than 280,000 older adults and found that those with the highest anticholinergic burden had a 120% higher risk of dementia within 10 years, more than double. And the overwhelming majority of participants had no idea they were taking anticholinergic medications at all because nobody had used that word with them. Nobody had connected the bottles. Nobody had done the math. What happened with Harold over the next 6 months was not miraculous. Medicine rarely produces miracles. What it produced was a systematic, medically supervised review of every prescription, every over-the-counter product, every supplement. We identified the combined anticholinergic load. We worked with his primary care physician to find alternatives where they existed and to discontinue what was no longer necessary. His diphenhydramine was replaced with a low-dose melatonin protocol. His oxybutynin was transitioned to mirabegron. His amitriptyline was tapered and replaced with a topical nerve pain treatment. The quetiapine was slowly removed under careful supervision. By the 4-month mark, Harold's daughter called me from Tennessee. She said her father had walked out to the barn that morning on his own, something he had not done in nearly a year. He had told her the names of each of his grandchildren without prompting. He was not the same man he was at 50, but he was Harold Jones again, in the ways that mattered to his family. Medication-induced cognitive decline is often reversible when it is identified early enough. That is the most hopeful sentence I can offer you, and I want it to land. The brain is far more resilient than the aging narrative suggests, but only when the source of harm is removed. The key phrase there is identified. Most of it never gets identified because nobody looks. Nobody adds up the burden. Nobody connects the cognitive fog to the medicine cabinet 2 feet away. Here is what I want you to do with this information. First, write down every medication you are taking, every prescription drug, every over-the-counter product, every sleep aid, every allergy pill, every stomach medication. Write them all down. Second, bring that list to your doctor or pharmacist and ask one specific question. What is my total anticholinergic burden? There are standardized scoring tools available for this exact calculation. If the answer comes back high, ask about alternatives for the highest burden medications. If you are a family member watching this for someone you love, you have the same right to ask those questions on their behalf. Many of the families sitting across from me had no idea that a medication review was even a possibility. They assumed the prescriptions were permanent. They assumed the decline was disease. In many cases, it was not. Stanford Medicine has been advancing research into what is now called pharmacogenic cognitive aging, the study of how cumulative medication exposure accelerates or mimics the appearance of dementia. The findings consistently support what I have seen in clinical practice: reduce the burden, and many patients regain meaningful function. Not all of it, but enough. Before you go, I want you to hear one more thing about Harold. At our final clinic appointment, about 8 months after we started the medication review, he brought me a jar of honey from his farm. Tennessee wildflower honey, he told me, best in the county. He said he wanted me to have it because I had given him something back that he thought was gone. I did not give Harold anything. I removed what was taking things from him. That distinction matters because your brain, even at 70 or 75 or 80, has not surrendered. It is waiting. Give it a chance to show you what it can still do. Now, of the 9 medications I covered today, how many are in your medicine cabinet right now? Tell me in the comments. And tell me whether you have ever had a full medication review, because the answer might be the exact thing someone else watching this video needed to see. Share this with someone who needs it. Your brother who is on 4 prescriptions and cannot remember appointments. Your mother who is taking a sleep aid every night and feels foggy every morning. The information in this video costs nothing to pass along, and it might change everything. I am Dr. William Lee. Remember, consistency beats perfection every single time. Take care of yourselves, and I will see you in the next one.